I'm Vin Kim Nguyen, and I'm co-director with Suri Moon of the Global Health Center. And I have been I'm honored to open this panel. Excellencies, distinguished panelists, colleagues, and friends. First, a minor housekeeping issue for those who are interested in accessing the recording. Is that better? So for those of you who will want to access the recording, it will be on ghplatform.org by the end of the week. So as I've already said, it's really an honor to introduce this important panel. It's a key moment. It's 6 years after COVID, a year after adopting the pandemic agreement. We're in the thick of the PABS negotiations, and we have the hantavirus epidemic, which is unfolding, and since a few days, though actually probably a few weeks, the Ebola Bundibugyo strain in DRC and Uganda. I'm going to refrain from commenting on that because I worked in DRC in a number of Ebola epidemics, but I will say one thing, which is that it is pretty unsurprising that we have another epidemic of Ebola there. But let's try and dig a little bit deeper. I think it's important to keep in mind that four forces are reshaping the pandemic terrain as we speak, sort of a bigger picture here. The first one is AI and data capture driven by massive economic interests, the tech lobby. You will be familiar with terms that have arisen in response, such as data sovereignty, techno-feudalism, and surveillance capitalism. The second force reshaping the terrain on which the pandemics occur and are responded to are the powerful synergies between global heating, environmental instability, biodiversity collapse, and pathogen evolution and spread. The third, I think, is something that perhaps could not have been foreseen quite so clearly a few years ago. And that is that we have had spectacular improvements in human health worldwide, and they're leading to an unprecedented demographic shift, which is global aging. So this is exacerbated by plummeting birth rates, likely, if those of you read the FT story this weekend, turbocharged by smartphone usage. So why is aging relevant here? Well, it's because aging populations are increasingly reliant on pharmaceuticals and biomedical technologies to remain healthy. So we have aging and vulnerability as sort of twinned demographic vector. And what we've seen in the last few years is the weaponization of supply chains and development assistance to project state power. So I would argue that the pandemic terrain has been fundamentally shifted by these four developments, the last two of which perhaps not enough thought has been given. So until, I'm sort of tempted to draw an analogy between pandemics and climate science, and the idea of, introduced by the philosopher Timothy Morton, who refers to hyper-objects, which are things that are massively distributed and constituted across evolutionary timescales, microbial ecologies, climatic systems, and planetary biochemistry. So I'm not sure this is helpful, but I wanted to just remind us that pandemics are the surface manifestation of very, very, very big things that are not easy to comprehend and certainly can't be reduced to one disciplinary approach. So something to keep in mind. Pandemic preparedness has until now been articulated around data, design, infrastructure, and governance. And all of these face new challenges. The US-led trend towards not only sharing data, but just not collecting it. A growing sense that architecture or design is no longer fit for purpose, and a corresponding obsession with redesign, or a kind of an architecture-centeredness conducted in the same echo chambers, oblivious to how the ground underneath us has shifted. We're all aware of crumbling and underfunded infrastructure, and of course, the rupture, as my Prime Minister, Mark Carney, said notably a few months ago, a rupture in world order characterized by a US-led attack on multilateralism. This is a real tectonic shift. So, yet, pandemic preparedness remains largely confined to approaches derived from human medicine and epidemiology. As a result, one of the things that I think is important that we have seen in the last 20 years or so is that within this configuration of data design, infrastructure, and governance, preparedness has oscillated between two logics. On one hand, a logic of biosecurity, which you are all familiar with, and on the other hand, a humanitarian logic. Biosecurity is national security, protection, humanitarian as in saving lives and based on the idea that all lives are equal and all lives deserve to be lived. We saw with the first major Ebola epidemic in 2014 a contradiction between a tension between biosecurity and humanitarian logics. We saw how saving lives became about protecting particular populations and controlling other populations. I don't need to tell you which ones. With COVID, a third logic has appeared, the logic of sovereignty. Vaccine nationalism, supply chain weaponization, and other developments signaled the end of solidarity as anything more than rhetoric in global health, and the contradiction between, or the tension, I should say, between global health as low-threshold politics and global health as war by other means. Since the rupture of 2025, this contradiction has become powerfully evident. The PABS negotiations have revealed termites in the wood of the house that the architecture is building or has designed, the House of Global Health. That is the contradiction between the rhetoric of multilateralism and the reality of growing by and unilateralism. So that's maybe a lot of ideas, but what I wanted to really point to is something that I think we can all agree on. I was trying to be a bit provocative. One is that every pandemic or epidemic reveals contradictions. So this is something that I think is quite clear, that however prepared we are, we're always prepared for the last pandemic. And what our response does is it reveals contradictions in our response, which is a normal thing. I mean, it's not a bad thing. I'm just pointing that out. But that learning from these contradictions is very important. So every pandemic reveals a new logic and a new contradiction, and I think we have to be attentive to that and accept that. We know that preparedness has always been about power and not just data and governance. And I think something that really strikes me is how when we talk about pandemics, we're really trapped in a kind of a linear logic of cause and effect. And what we're dealing with is very complex systems, so we're not very well equipped epistemologically. So in summary, I think what I can say is that our center, the Global Health Center and the Governing Pandemics Initiative have been tracking the PABS deadlock, the IHR amendments, the financing gaps in real time. And what we do see is all three logics operating simultaneously with no agreed framework for resolving whatever contradictions there are between them. I will close by saying I look forward to the insights of our distinguished and experienced panelists, and it is now my pleasure to pass the floor to the Right Honorable Helen Clark.
Well, many thanks to the Graduate Institute for hosting this event again. It's become a WHA week standard item in the diary, and let's keep the focus on pandemic issues in this way. Greetings to moderators, fellow panelists, audience here and online, and can I particularly single out the representatives of the Government of Ghana who are here, Mr. Desmond Boateng, who's going to address us after I've spoken. We're obviously noticing the leadership that President Mahama is giving around Africa Reset and conversations about architecture, so we're thrilled to have you here for this event, Desmond. So, at the independent panel for Pandemic Preparedness and Response, it's still going. Ellen Sirleaf and I are still co-chairs, 5 years on exactly from the 2021 report to the World Health Assembly. And we've continued to work to provide what we hope is an independent and evidence-based voice on pandemic prevention, preparedness and response, focused on that big question, are we ready? And if we're not, what do we need to do? Of course, to recap briefly, you're an informed audience. Things are changing. We have the new international health regulations, amendments in force, and I think we saw them put to the test with hantavirus, and saw once the case was notified by the UK authorities, having had tests from South Africa, WHO was notified, things spun along, and we've seen rapid multinational coordination. So a test, and by and large, definitely give it a pass mark. Last year, of course, the pandemic agreement text was adopted, but as we're all aware, the agreement can't move forward without the PABS annex. And the annex, of course, gets us to the heart of the tensions around the COVID-19 response, that there was not equitable access to countermeasures. And so it is not a surprise that voices for equity and justice want to see this properly addressed in the PABS annex before the whole agreement can move forward. We know in this area there's a fundamental asymmetry. Vaccines have long been largely manufactured in high-income countries, and they're slow to get out to anyone else. So we do hope that the member states can sort of come together around a solution on PABS, because it would be a great misfortune indeed if so much work hadn't gone into the agreement and now the discussions on the annex were to go nowhere. A failure of multilateralism, to put a line under it, if that were to happen. But at the independent panel, we continue to say, don't sit around and wait until you have an agreement. There is work to do. Work to do at the national level, work to do at the regional level, work to implement the IHR fully. We are highlighting the need for a proper monitoring ecosystem. We don't see that quite in place at the moment. And of course, financing is still rather a large issue. The pandemic fund never got the funds that was anticipated would be needed for preparedness. And if a pandemic threat arose tomorrow, we would be scrambling again for emergency funds, because there's not a mechanism to deal with that adequately at this point. On the monitoring issue, to know where to best invest your dollars at the national level, you need to know where the risk is greatest and to have at least some broad idea of the range of options you are preparing for. The independent panel has issued a new report this week around the monitoring issues, taking a comprehensive approach from identification of range of risks through to preparedness and response capacity. Now, one issue that's heavily debated this week, and of course in the year leading up to it, and is the subject of countless dozens of reports, op-eds and the rest of it, is the global health architecture. And I think, myself, the global health architecture discussions have started at the wrong place. They're looking at structures and efficiencies. I think you need to start with people, and what are people's needs, and then what are countries' needs, and build on up. And in that architecture, it will be very important to keep advocating for PPPR to be a priority. I go to some discussions where people say, look, if we just have universal health coverage, it's all solved. I don't think it is. Universal health coverage is like a platform, and on the platform, you must build your PPR. You must build the range of issues that need to be prioritised. So, later in the year, of course, there is the UN high-level meeting on pandemic prevention, preparedness and response. And given that the PABS annex is not completed, the high-level meeting could serve a very useful purpose in endeavouring to rally momentum around moving forward on that, and then to implementation and ratification stage and the independent panel again has put out, with friends, a paper on asks for the high-level meeting to try and get it to be concrete and not abstract and cliched in its declarations. I might say an early concern is that apparently member states in New York have put the high-level meeting on the Friday of the high-level week, where, as you will be aware, generally people are on the planes back home. So whether that can be changed, I'm not sure at this point. So that's just a bit of an overview from the independent panel. And it's now my pleasant duty to welcome you, Desmond Boateng, as a special representative of your president, to come and address us. Thank you.
Distinguished Chair, Excellencies, Heads of States and Government, Honorable Ministers, colleagues, ladies and gentlemen. On behalf of the people of Ghana, of the government of Ghana, I wish to express my sincere appreciation to the organizers for convening this important dialogue, and to all partners and stakeholders for their continued commitment to strengthening global health security. The COVID-19 pandemic was one of the defining crises of our generation. It exposed not only the weaknesses within our health systems, but also the fragility of our economies, supply chains, governance structures, and social systems. Above all, it reminded us that in an interconnected world, no country is immune from global health threats. Today, an important question confronts us all. Are we truly better prepared for the next pandemic than we were in 2020? While important progress has been made, we must answer this question with honesty and humility. We have strengthened surveillance systems, expanded scientific collaboration, and advanced important global discussions on preparedness. Yet, recent outbreaks across different regions continue to remind us that pandemic threats remain real, dynamic, and capable of spreading rapidly across borders. One of the clearest lessons from COVID-19 is that preparedness cannot remain reactive. The world cannot afford a cycle of panic during crisis, followed by complacency once the immediate threat subsides. Preparedness must therefore become a permanent national and global priority, grounded in prevention, resilience, and early action. This requires sustained investment in surveillance systems, laboratories, workforce development, emergency coordination, and resilient health systems at both national and community levels. It also requires strong and consistent political leadership. Importantly, the future of preparedness must place greater emphasis on prevention at source. Climate change, environmental degradation, rapid urbanization, and changing patterns of interaction between humans and animals are increasing the risk of emerging infectious diseases. This is why the One Health approach must move beyond rhetoric and become operational reality. In Ghana, we are strengthening multi-sectorial collaboration across human health, animal health, and environmental sectors as part of our broader health security agenda. We are also advancing a new national action plan for health security to strengthen preparedness capacities, improve coordination, and build resilience across all levels of government. Excellencies, COVID-19 also exposed deep global inequalities in access to vaccines, diagnostics, therapeutics, financing, and manufacturing capacities. No region should again find itself at the back of the queue during a global emergency. The future of preparedness must therefore be not only more responsive, but also more equitable and self-sustaining. Countries and regions must be empowered to build stronger domestic systems, regional manufacturing capacity, intelligent surveillance infrastructure, and sustainable preparedness mechanisms. Strengthening local production, technology transfer, and regional cooperation will be essential to reducing vulnerabilities during future crises. At the same time, preparedness systems must become more intelligent and interconnected. We must move beyond fragmented systems toward integrated data and surveillance architectures capable of supporting faster detection, risk assessment, and decision-making. Emerging technologies, including artificial intelligence, offer important opportunities to strengthen early warning systems and public health response capacities. Ghana recently launched a national artificial intelligence strategy as part of our broader commitment to harness innovation responsibly for national development and resilience. However, innovation must always be guided by ethics, inclusion, trust, and responsible governance. Excellencies, preparedness also requires sustainable financing and stronger multilateral cooperation. Mechanisms such as the Pandemic Fund are important steps forward, but financing must remain predictable, sustained, and aligned with national priorities. No country can address pandemic threats alone. Our collective security will depend on stronger global solidarity, transparent information sharing, sustained investment, and effective multilateralism. In this regard, the World Health Organization remains central to global preparedness and response efforts and must continue to be fully supported. The next pandemic is not a question of if, but when. Our responsibility, therefore, is not only to respond more effectively to future crises, but to prevent them where possible, dictate them earlier, and protect populations more equitably. History will judge us not simply by what we learned from COVID-19, but by whether we transformed those lessons into stronger systems, fairer partnerships, and a safer future for humanity. I thank you for your kind attention.
not tall enough to take the risk of trying to jump down. Good afternoon, everyone. My name is Ebere Okereke, and I have the honour of moderating this first panel, and glad to see my panellists coming onto the stage. The challenge. So I am not going to spend time introducing the panellists because we're running a little late, and I'd rather spend the time on the actual conversation. Thank you, Professor Nguyen and Helen and Dr. Bateng for your setting the scene. We've been talking about the pandemic treaty, PABS negotiation, and in the last few weeks we've had evidence of why we need to move these processes and these systems along. The concern that we are still not yet there with the PABS agreement, which is required for the pandemic treaty to be fully ratified and operational, is the issue we're going to be exploring with this panel. So the question is, where are we? We adopted the pandemic treaty. We've been negotiating the PABS for a long time. It appears that from the reports that we've had that there is still a gap between those countries that are most significantly affected by pandemics and outbreaks and other things and the global consensus. So what I'm hoping to achieve in the conversation with this panel here is an understanding of what is it going to take for us to get there. And we need to remember that we have actually made some progress. The lessons from COVID-19 are being addressed. We had the IHR amendments adopted and in place. And as has been reported, it appears that they have been very positively implemented in response to the hantavirus outbreak and the cruise ship. And now, as we speak, there's a very accelerated response to the latest Ebola outbreak in the DRC, and we hear very positive feedback about operational research to actually try new treatments and vaccines as part of the response. So that's encouraging. But we also know that that's not enough. And we're having this conversation at the same time when we're talking about reforming the whole global health architecture. Our representative from Ghana government touched on some of the initiatives they're taking around recognizing the role of countries in actually owning the responsibility for preparedness and aligning that with their broader health needs. So we can't continue to talk about pandemic preparedness separate from the broader health system and a capacity for countries to actually provide health and therefore prepare for pandemics. So we have the plus side of what's happened so far, but we need to actually recognize that with WHO, Africa CDC, both declaring public health, the fakes and the FECs, I hope I got those acronyms right. So the public health emergency of international concern and public health emergency of continental security. What's going to be different because we have these two instruments declared compared to the last time? So I have the pleasure of having within this panel people who have been directly involved in that conversation. And so I'd like to, I will stand, I'm more comfortable standing if that's okay from the panel. I'd like to go straight to my first panelist, and we have Her Excellency Hanan Kuwari, who is actually the Vice Chair of the Intergovernmental Working Group and advisor to the Prime Minister of Qatar, and has been leading the discussions around the PABS negotiation. So I'd like to hear from you. Where are we? Where are we going?
Thank you very much. First, I'm really glad to be here with you today. So the adoption of the pandemic agreement text last year was an important achievement for global health. It demonstrated that countries, despite all the geopolitical pressures, retained the political will to negotiate and reach collective commitments. We should not underestimate that really important achievement. However, we all know that the pandemic agreement without the PABS annex is incomplete. PABS is not just a technical annex, it is the core equity commitment of the entire architecture. It determines whether the country that rapidly shares a pathogen sample will actually benefit from the vaccines and treatments that follow. Until that is resolved, the agreement cannot be signed or ratified. The work is not finished yet, but I would like to acknowledge here what is happening in the negotiation room. The member states engaged in these discussions, including those with very different starting positions have shown genuine commitment to getting this complex technical annex right. That sustained engagement through months of difficult and detailed work deserves recognition. It tells me that the political will to finalize the PABS annex is there. What we now need is to translate it into a concluded text. You ask, what will it take? Well, the recent hantavirus cluster has reminded all of us once again why a global health institution like WHO is indispensable, not just as an administrative body, but as the institution that can interpret findings, assess and communicate the evidence, and propose science-based measures to protect populations worldwide. These functions depend on countries sharing data rapidly and openly, as well as on a WHO that is fully funded and retaining competent staff able to interpret the evidence and informing the decision makers and the public. A well-designed PABS will encourage countries to share data openly. They will do that without reservation if they trust that the benefits, the diagnostics, the treatments, and vaccines will reach their people as necessary. That is the main issue. Trust among member states. Trust amongst member states, trust with private players, and with institutional organizations. And of course, the willingness by all parties to make a step towards each other and find an acceptable compromise, as in all negotiations. And I will be honest, the trust required to conclude PABS does not yet fully exist. And when I say this, I'm not speaking in abstractions. Trust was weakened and jeopardized by specific facts during the COVID-19. When South Africa rapidly sequenced and shared the Omicron variant, exactly what the global health agreements ask countries to do, more than 50 countries responded with immediate travel bans. The TRIPS waiver, which could have enabled local vaccine production in the countries that needed it most, did not receive the support required, reflecting the difficult tensions between global equity commitments and industrial needs. Vaccines were not distributed equally, and health workers in poor nations went unprotected for months. These are not system failures in the abstract sense. These were decisions. That history sits at the PABS negotiating table with every delegation. That is why regaining trust is not a diplomatic formality. It is the operational precondition for PABS to work. Member states need to be convinced that if countries commit now to a fair new approach, those commitments will be honored. That is why I return to implementation. We already have the amended international health regulations in force. If we demonstrate that existing commitments are honored, that the system actually delivers what it promises, we begin to rebuild the evidence that trust requires. Implementation is not secondary to negotiations. It is the foundation upon which the next negotiation is built. And it is on that foundation that the PABS annex can be concluded. Thank you.
Thank you very much. Thank you very much. That was a very clear statement of the challenge, and the word trust, I think we will be returning to over and over. I think that's actually the biggest hurdle, is how do we build trust back into the system, not just at the global diplomatic negotiation, but all the way down to the front line. There's a lot of concern about loss of trust between individuals and their health professionals, between health professionals and the health system, and between governments and the multilateral ecosystem. And we need to address it at all levels. So thank you very much for that. But I would like to ask one quick follow-on question from you. You're a senior voice from the Gulf region, and this is a region that has the potential, in my view, and I will declare that I am a biased moderator, to play a bridging role in what is often seen as the North-South divide in the negotiations around PABS and other global health challenges. So what do you see as the opportunities for countries like Qatar to be among, as the Canadian minister said, the middle powers to actually move some of this trust issue and the diplomatic conversation forward?
Definitely, Qatar is extremely interested in supporting multilateralism and in playing the potential of the full role of the middle role, as you mentioned, and we're very active in that area. And myself, I'm extremely committed to multilateralism, and I hope that through the engagements and the work we are doing in WHO and in other organizations, we can continue to support and bridge the North-South divide, as you mentioned. However, I'd like that to be a plea for all countries that are in the middle ground to speak up, because we noticed in the PABS negotiations that many of the middle ground countries are not speaking up, and it's really important that those countries that are in the middle ground, like Qatar, like our region, to speak up and to support the negotiations and to help reach that compromise middle ground that we all need. Thank you.
Thank you very much. So we've added the second point of what we need to move forward. We've got trust and we need more voices. So let's, I'm going to move across to you, Ola. Ola is from the Health Emergency Governance and IHR part of WHO and has been supporting the Intergovernmental Working Group Secretariat. So, Ola, we're not going to restate the fact that we have two big outbreaks going on at the moment. Fakes have been declared, and we recognize immediately that there was a delay in picking up the Ebola outbreak in DRC. By the time it came to attention of international authorities, we estimate there were already a few hundred cases and a few dozen deaths. So in terms of preparedness, if we're marking homework today, we'll say we're not prepared. So the pandemic agreement, the preparedness part of the pandemic agreement is what is most important in terms of finding every pandemic, every outbreak starts with that first case. How are we making progress in terms of coming closer to that first case?
Thank you very much, and it's a pleasure to be with you today. It's a privilege to be on this esteemed panel and to speak after Her Excellency, Dr. Hanan. So I'd actually like to come back to you, Madam Moderator. It starts with the IHR. So the prevention actually starts with the IHR before it even gets to the WHO pandemic agreement, because that is the legally binding framework when it comes to the detection, when it comes to the reporting, and when it comes to the prevention of the spread of disease. That is the core of the IHR. Are we there or are we not there? Yes, we are there in certain aspects. So like you rightly mentioned, there was a delay in reporting the signal. But once it was reported, if we look since the day it was reported, the sequence of events that has happened since then has showed that the world has taken on more seriously implementation of the amendments to the IHR. That WHO has exercised its authority that's given within the IHR. And to give you a clear example of that, if we look at the recent Ebola pandemic public health emergency of international concern, this is the first time where the Director General used his authority to determine a public health emergency of international concern without first convening an emergency committee under Article 12.2. I think that is a strong message. That shows you that we are moving more towards taking action and using the tools we have at hand. So what do we need to do? We need to look at those tools that we have. We need to look at the IHR. We need to interpret the articles in a way that can strengthen our collective systems. And what I wanted to start with, that I forgot to, is I'd like to start with three words: the world together. Because if we look at hantavirus over the past few weeks, and if we look at Ebola since this weekend, I believe, it tells us one thing: that a threat in one place is a threat to everyone. And that's why, if you can please remember those three words, the world together. And I look out here to Ricardo. Ricardo, I see you there. You know what the world together means. And we'll come back at the end to why those three words are important. But again, in the world we live in today, with all the climate crises, with the interconnectedness of our world, with the population mobility, with complex settings, vulnerabilities, humanitarian events that happen, these are all ingredients for where infectious diseases can start and can spread. That's why we need to be more prepared. I'd like to end with one thing, that in all of this, it's really speed is of the essence. So speed in detecting speed in surveillance, speed in reporting, and speed in coordinating the action at the national level, the regional level, and then the international coordination is really what helps us to move forward. So maybe I'll stop there.
Thank you. And I will pick you up on that. We also hope that we don't see speed in adverse responses, because that speed in pulling up the drawbridge and closing borders, which doesn't help, is part of what we want to avoid. So I want to ask you a question, and I acknowledge what you say about the IHR amendments are working, and we're really excited to see that. But the question is, in the absence of a finalized PAB annex, and therefore a non-ratification of a pandemic treaty, the Ebola virus outbreak in DRC today is a new strain. We don't have medical countermeasures for vaccines or therapeutics. So we're relying on the traditional infection prevention and control approach. And like you said, the traditional, that in itself requires speed and a coordinated response. But if a novel pathogen were to emerge now, while we're still negotiating the PABS annex, what practically happens? What are the current mechanisms for deciding on what basis, and particularly ensuring that we don't have a repeat of the equity failures that we saw during COVID?
Thank you. So again, if we look at where we are today, it's not really a hypothetical example, right? We do have a disease outbreak. As you rightly mentioned, we do not have a vaccine for it. We do not have a therapeutic for it yet. But what immediately has been activated by the international community is the R&D ecosystem. So as we speak today, later today, an emergency committee will be convened by the Director General, where they will provide temporary recommendations to countries that are impacted, to countries that are neighboring those impacted countries, and to other countries. So that's the first step. Second step, if we look at it tomorrow, the technical advisory group will be meeting, which will also provide recommendations. Are there candidate vaccines out there? Are there candidate therapeutics that can be used? So what we need to really do, and maybe here is where we can come back and look at some of the provisions of the WHO pandemic agreement that was adopted by member states last year. I'd invite you to look at the articles. If we start at Article 4, which speaks about surveillance and prevention, that's the first step. If we start looking at what we need to do there, move from there to the article on prevention and One Health. Again, we have actions that member states have agreed based on the shortcomings during COVID, based on the shortcomings during other outbreaks. This is what we need to get our systems in place. That relies on a strong health system, right? On health workforce, on frontline workers. That's what's under Article 6 and Article 7 of the WHO Pandemic Agreement. Okay, you reached that, but now we need to move more into the research and development. We go to Article 9. So really, if you look at those articles one by one, and then you move into the technology transfer, you move into the article on diversified manufacturing and capacity, it shows you that member states have acknowledged, the international community has acknowledged that there is a systematic way that we can prevent. If we don't succeed in the prevention part, we can prepare for the next stage. And if we miss that mark as well, how do we respond more effectively? And that takes us all the way down to Article 12, and under the leadership of Her Excellency and the rest of the Bureau, they lead in the negotiation of spelling out how the access and benefit sharing will be done. Then we move into supply chains, one of the biggest hurdles, supply chains. How do we get things over? So just to summarize and say, really, we have the system. I'd like to echo what the Right Honorable Helen Clark said earlier. Let's not wait for the pandemic agreement to come into force. Let's not wait for its entry into force. Let's start now building on that. And I'd like to conclude with one thing. Yesterday, 64 member states spoke during this session in Committee A at the World Health Assembly. I think 5 or 6 spoke on behalf of regions. But if we take a core message that was repeated throughout, let us not wait. Let us start using the tools we have the best way we can.
Thank you very much. Thank you. I think that's worth a capture. I go to Edem now. Edem and I go back a long way, and we have interesting debates about the rhetoric of global health and the reality on the ground. All of that we've talked about, the bottom line, it falls on country, at country level. And that preparedness at country level requires investment. And we're not just investment in the architecture of emergency response, but the actual foundational health system itself, because there is no emergency response, there's no emergency preparedness if you don't have a health system that is functional. And again, that issue of trust comes back into it. If the society don't trust that the health system looks after them in peacetime, they won't trust it in an emergency. So, Adam, the Minister Dembi couldn't join us this afternoon, but in a session he was in earlier this week, he talked about the tiny fiscal space within which all the countries are expected to deliver universal health coverage, resilient and good quality health systems that build trust in their societies, and preparedness for emergency preparedness and response, without often being influential and powerful voices in the rooms where the discussions about what matters and what's important happens, which is why the equity conversation continues to, I think, stall the conversations, as Her Excellency said, about the PABS annex. So you have been, have been one of the voices and the champions and the behind the scenes of the Accra Reset agenda, which is one of the many initiatives, and we heard about multiple initiatives at the moment, but yesterday we were all at the global campus and all roads were leading to the Accra Reset meeting yesterday, showing that there was a true interest in what was different about what you were doing there. So how does the Accra Reset, it's generated all this momentum and a lot of conversation, but when we look specifically at pandemic preparedness, prevention and response, what does the Accra Reset agenda, how does it connect to this global conversation?
Thank you, Barry, and thanks for reminding me that we've been having these debates for a while, and also for, and in another capacity as co-chair of the External Advisory Council of the Pandemic Fund, those debates have continued, and I'm pretty impressed with some of the work that is taking place, countries that are benefiting from the fund, capacities that are being built. But what the Ebola, the current pandemic, this Ebola in Ituri, currently in DRC, tells us is we're really still not prepared. And sadly, we're not prepared because if we go granular and try to understand, and I think so my co-panelists have touched on some of that, which is it took probably quite a month for from detection all the way to get into testing, and then eventually transmitting samples from communities, from village communities, all the way to specialized labs. And through that process, we saw more infections might have taken place, right? But what we shouldn't miss is that in this process, the ability to detect was simply because of an inability of or unavailability of a broad spectrum diagnostic to be able to test for this particular, because this particular variant, which is not a Zaire variant, is 30%, has 30% variance, right? So clearly we missed that. And so what it tells us that no matter how much preparation you put in place, if it's not comprehensive, you miss that process. And then now we're talking about, again, a country that since 1976 has had cyclical events of pandemics with Ebola, and still at this stage does not have the ability to have the diagnostic to be able to deal with detection at source. That's one issue that tells us we're definitely not prepared, right? And I'm going to put this in the context of how Accra Reset would be responding or is approaching this particular predicament that we have. So that's one issue. The other issue is these. So basically, I'm talking about surveillance in this case. But then there's also the gap we have in fiscal, which you touched on, that these countries have really, really serious fiscal constraints in terms of budget, because what they need to be doing basically is putting personnel, putting investments in building facilities, but all of these resources they have, a significant portion is used in servicing debts. Uganda is under economic debt strains. So is DRC and many other countries in Africa. And then thirdly, there is the manufacturing gap as well. I mean, it strikes me that a country like Senegal has an Institute Pasteur, for example, that has been producing vaccines for 80 years. It's probably the only lab on the continent, or that facility in the continent that's been producing vaccine, one particular vaccine for 80 years. For a continent that for 80 years has been producing just one vaccine, tells you there's something wrong with our industrial strategy as well. So the manufacturing gap, the fiscal gap, and also the capacity gap still remains. So no matter how much, I mean, and I'm great and glad to hear that a lot of these instruments are being put in place. What Accra Reset brings to the table is, how do you take all of that and put it on the ground to measure how it relates to the response you need on the ground? So for example, in this Ebola case, the question we'll be asking, or the question we are asking the high-level panel, which is the three interlocking, if you like, departments of Accra Reset, as far as health is concerned, is to say, the high-levels panel's job is to say, what within the current architecture, whether it's the incentive structure, whether it's the instruments and tools, that makes it hard or needs to be dealt with to ensure that a town like Ituri gets the kind of attention it needs to allow supplies or systems to get to it early enough to be able to do the kind of detection they need in terms of preparedness and response. So that would be the question. So the high levels panel's job is basically to say what needs to be done that hasn't been done. Then there is the RIO, which is the interlocking observatory, okay, whose job is just basically to try to understand that in these global institutions that we have, and we can name some of them, there's the Global Fund, there's Gavi, all of them have solutions that touch the ground. They have solutions that could impact upon things that are happening in the ground. And how do we coordinate that mechanisms they have, those solutions they have, that so they are not disaggregated, they are not siloed, and that they can respond almost quickly to what is happening on the ground. And then the last one is basically HINGE, which is the health investment enabler that countries have to put in place, which is that what opportunities exist currently that enables private sector within those countries to see not these things as just problems and challenges, but opportunities that should attract the kind of investments. During the pandemic, we saw so much goodwill from private sector globally, but more importantly, across the continent, where institutions that have massive capabilities in things like supply chains, brought that to bear to provide support to countries. But we think we seem to have wasted the pandemic because everybody has gone back doing what they're doing. I mean, we saw aviation industries that have reformed a lot of how they do business in terms of investments they've made into things like contact tracing, technologies to be able to improve even filtration clinics and things like that. So if we can leverage some of those capacities that exist in the private sector, and right on the back of that to drive the kind of investments into some of these issues we are seeing, which we think are challenges, but we should see almost as opportunities for us to begin to think different. And that's the kind of support that HINGE will bring into an equation like this. Thank you.
Thank you very much there, Dan. So I see from what you described is the Accra Reset agenda, and that movement is connecting the frameworks, the global ambitions, the global goals into the reality of the context on the ground and bringing local players into that. And I think that is a necessary part of the equity issue, in the sense that we can't have very lofty ideas about what should happen if we don't recognize what facilities are available on the ground. And so I think that feels like a really good place to bring this discussion to a close. And the key message I would actually want to leave for us at this session is the issue of trust at all levels. I think that captures the challenge from local to global, and is the hurdle, like Her Excellency said, that we need to pass if we're to get PABs agreed, the pandemic treaty adopted, and for a real change in how we respond to the next pandemic. And so I'd like to thank my panelists, and I invite them to leave the ground and pass the baton to Richard. Thank you very much.
Thanks, everybody. Can I invite our second panel up, please? You've already been introduced to the Right Honourable Helen Clark, the co-chair of the independent panel. Let me also warmly invite Mariangela Simao, the Secretary of Health, and environmental surveillance for the Ministry of Health in Brazil, Els Turile, who's here as an as the senior expert in health equity and an advisor to the independent panel, and of course, Maria Guevara, the International Medical Secretary of Médecins Sans Frontières. This panel is going to focus a little bit more on practice and move beyond theory. But we do so, and let's be very clear about this, at a time when certainly in my working life, which is many decades, I've never seen countries more polarized. The world is definitely not together. There have been glimmers of hope. In April in Lyon, President Macron held a One Health summit, emphasized the importance of viral spillovers, zoonotic infections, primary surveillance, primary prevention, One Health surveillance. The G7 meeting is in Evian in just a few weeks' time in the middle of June, and One Health will be on the agenda of the G7. So there is some political leadership, but the lessons of COVID-19, the importance of solidarity, interdependence, have most definitely not been learned. In fact, on the contrary, the rise of populist nationalism is driving countries ever further apart. Global health seems to have entered a period where the strong believe that they can use their wealth and power to dominate over others. Hardly the conditions for pandemic prevention, preparedness, and response. So, first question to this amazing panel. Are we ready, Els, for the next pandemic? One word.
No.
Are we ready, Mariangela?
No.
Are we ready, Maria?
Absolutely not.
Are we ready, Helen?
No.
Okay. Thank you for coming this afternoon. So let's dive into that in a little bit more detail. And I'm going to start with Helen. Co-chair of the independent panel, Helen, you have got unique insight, having worked on this issue for many years now. Can you give us your overall assessment of the pandemic prevention, preparedness and response system today? Where are we?
So it's been sobering, hasn't it, listening to the last panel, because we have these updated IHR, but really it means nothing if back downstream basic things aren't done. So we can say yes at the point of actual confirmation of the presence of a virus, the system kind of swings into place. But how do we get there? And that comes back to this question, are we ready? And I think we need a lot more focus on knowing your risk. What are you looking out for? What are you preparing for? One very senior former WHO source I ran into in a car park yesterday said to me that with respect to the late confirmation of this Bundi Bugyu virus, they were looking for something else. He said, basic observation, if it looks like a duck, quacks like a duck, walks like a duck, it probably is a duck. And that perhaps, first lesson of medicine, observe the patient. Maybe he said we've become too reliant on tests, laboratory, etc., but follow your gut, but know your risk. We know Ebola in various forms is endemic in the area. I think a bit the same with hantavirus. Hantavirus is endemic in Patagonia. Ships are leaving almost by the day and the season out of Ushuaia. They go down to Antarctica, they come up through the Atlantic as this one was. So ding, ding, ding. Does anyone brief cruise ship captains and the companies that this is an endemic virus and people are all on board, think in a precautionary way? So we can have perfect rules, but if we're not risk-informed, if we're not, alert to the possibility of endemic viruses emerging, none of it's going to count for much, is it?
It sure ain't. And so therefore, at the high-level meeting, is that just another talking shop that's going to take place in September? Or what should our ambition be for that high-level meeting?
Well, it could get more concrete and more concrete around actually, getting enthusiasm for finishing the PABs, getting enthusiasm for implementation, proper monitoring systems. But I think it needs to bang a bit of a drum on finance, because we're talking global public goods here. Global public goods. If disease gets away, it knows no boundary of geography, border, sovereignty, gender, whatever. It's away. It's a global public good to stop disease. That's why we have Gavi as a fund. That's why we have the Global Fund as a fund. We need new ways of funding global public goods like preparedness. But some of the bold ideas out there, like global public investment, need member state champions, because you're never going to change financing unless member states say we've got to have a new way. And just to remind people, the global public investment model talks about everybody putting into the fund, allocation according to need, and then the governance changes to be much fairer, because again, in the governance of existing funds and structures, it's weighted to the north, which puts up the money. But if everyone's putting up the money, the low-income countries get more say, the emerging economies will be paying more and get more say, and the north will get, an appropriate say, but not the kind of domination that it's had.
Thank you, Helen. Mariangela, as the world spotlight turned towards Latin America with hantavirus, can you tell us a little bit about how you feel Latin America is prepared today?
First, I want to react to Helen.
Please.
Doc example, because sometimes, like in dengue fever, a patient with a febrile, with fever, you think dengue first, but then it's not dengue, it's chikungunya, or maybe it's not chikungunya, it's Zika, and now we have Oropouche and we have some other virus. So actually we need to have access to diagnostics rapid, and that will help timely intervention. But we need to know what's going on. So, I'm sorry.
Think laterally is what I'm saying.
Yeah, no, of course, but I'm taking the opportunity to highlight, because at country level, it's not easy. Like you have this virus that you are beginning to identify, which is good, but then we need to, like hantavirus, you mentioned hantavirus, because it started in Argentina, and then Brazil has a large border with Argentina. But then initially, it's clinically similar to dengue in totally different treatments. You treat for hantavirus, and it's dengue, kills the patient. So that's the basic. So are we, in our region, I think I said no, we are not prepared globally, but I think there's a lot that can happen at country level that needs to be in place, that doesn't depend on global agreements, because each of us here who represent governments, we have a responsibility to our people, right? The Brazilians, we say brasileiros e brasileiras, because in Brazil you have to mention the feminine and then masculine. Right? No, so Latin America is more organized because of PAHO too. Because there's a good leadership in PAHO, and it's also helping the countries come around in different agendas, and especially on local production. And but we do have two dissidents, right? In PAHO, Argentina and the U.S. So it's not saying PAHO, I'm saying in the Americas region, and this has led to problems that we did not expect to have. For example, the measles outbreak. How can you imagine we're going to have a measles outbreak? Is that an emergency? It is, because it's the highest contagious virus that we know of, and come on, guys. Vaccine is good and safe and been there forever, right? So I think we are better prepared in some ways, but not in others, because for diseases that are re-emerging, we are not prepared.
Yeah. Thank you. And in fact, in the latest report from the independent panel, there's a particular emphasis on regional networks and regional surveillance. We shouldn't always be looking to the global. And actually, you really underline that point, Mariangela, so thank you. Els, now you've been working on an MPOX report for the independent panel, and I believe that report is going to be coming out in the next few weeks. Why don't you give us a little preview of the work you've been doing on that and the key lessons that have emerged so far from the MPOX story?
Yeah, thanks so much. And indeed, I've been talking to quite a number of people that were involved in this in the MPOX response, and we wrote with the independent panel, published in The Lancet, a commentary in 2023 saying we need to stop outbreaks when and where they occur. And this is the repeated lesson that we don't seem to be able to learn. And when you think about the MPOX response, I mean, we failed like miserably all over these past couple of years. Because when you think about it, before 2022, MPOX was a zoonotic disease. There was an animal reservoir. There were sporadic spillovers with very short human-to-human transmission chains. And it was largely neglected. Nobody cared about that until, because we didn't do anything, but until there was a mutation, a variant that occurred that created an international outbreak, the fake from 2022-2023. And then suddenly we realized, well, actually we have vaccines. We have stockpiles of vaccines for health security, developed with the idea of protection against smallpox, but they actually are probably going to work against MPOX. And then suddenly they were made available, mostly in the Americas and in Europe. But none of these vaccines actually arrived at the endemic area back then during the international outbreak, nor after. And and it was actually shown that they were effective, the vaccines. And then the outbreak subsided, and nothing was done, nor to make available vaccines in those regions, etc., until inevitably we have another outbreak in 2024-2026. And so what has happened now, again, new variants, and what has happened now is that the MPOX has established itself in the human reservoir. It is being transmitted from human to human, multiple variants, and what the scientists have shown is that basically by being in humans, there is some interaction between a human protein and the virus that creates additional mutations in the virus. So we've actually created the perfect environment for more and potentially more aggressive variants to arise. So that kind of like, by failing to act locally when and where it occurs, we've created a potential monster. I think that that's a really important lesson. The other is, you know, we all talk about countermeasures. There was a vaccine. Certainly, well, when the second fake was declared, we knew there was an effective vaccine. And again, it wasn't made available until a lot of delay because there was no registration. For whatever reason that I don't understand, WHO pre-qualification was requested even though the vaccine was registered by the FDA, EMA, and had been shown in the initial outbreak, in the global outbreak, to be effective. So delay upon delay, and then ultimately, you know, the continent is dependent on donations, they trickle in, it's all complicated, a lot of contracts that need to be signed. And so in the end, I think probably 5 million vaccines have been delivered. But when I hear from the people that were involved, it was kind of like too little, too late, because in an epidemic response, vaccinating the right people at the right moment is critical to curb the pandemic. Otherwise, you know, I mean, one country said, well, we received the vaccines when we didn't have cases anymore. I don't know whether they ended up administering them, but this is kind of like we were unable, I think, to use the vaccines that have costed a lot of money in a way that really could impact the pandemic, because again, we were not prepared. There were no pre-positioned stockpiles in the endemic region where it should have been. And we come back to the diagnostic. In DRC, the most affected country, I think only 23% of all cases were ultimately confirmed. Because, I mean, bringing those samples for PCR testing to Kinshasa or even in regional capitals it takes too long. And so we need this multiplex, another speaker said it already, easy to use where the outbreaks occur, such that you can really quickly monitor that together with clinical observers, and then you can act if you have pre-positioned stockpiles of a vaccine that you know that works. Why aren't they available in the DRC already? So
okay,
I'm going to stop there.
So this report coming out in the next few weeks, so watch for that. Important. Thank you, Els. So we've heard about the global responses. We've heard about the importance of regional surveillance and response. We've heard about the contribution of the technical community. Maria, MSF is well known for its work in the field. What about the role of communities? When a pandemic threat is present, what role do communities have?
Well, everything. There are the first responders, they're both affected. But I think this is one of the things we needed to highlight again here about the role of the people. And I think one of the main implications or discussions around the people is, especially in the multilateral as we sit here, and even if it's under attack as we speak, it's really ensuring that the community actually has a voice. And that is what true equity means. Because without the community to tell you what they really need, you are not responding to the local. One of the main things that MSF does is, yes, we roll out a response for the outbreak. And here, what's happening in DRC, I've been there, I've worked in DRC since 2007-8. I went back in 2018 for the Ebola. Most likely will go back again. And the fact is, the system is broken and the community is not being able to access any type of healthcare. So if you look at the 2024 national immunization numbers data, their measles coverage is 55%. Why? Because the vaccines aren't coming there, even if they are existing. Their supplies are not there, even for delivery of it. You're talking about conflict areas where it's so inaccessible. And then the barriers of the administrative barriers that you have to hurdle through. And then you put on top of that cholera. They've seen the worst cholera outbreaks in almost all the provinces just in 2025. And you put Ebola on top of it. And then you want to be able to do the proper protocol on case management, proper case treatment, but they're inundated with all the other outbreaks. But the rest is also dying of maternal mortality, from malaria, from everything else, and you're expecting the community to be able to understand why you're coming in with a zoot suit. And when I was there in 2018, and this trust is really, again, important, our Ebola treatment center was one of the first ones in that area. But then it was burnt down because they didn't trust it. And when we went to the community, they told us, but where's our water? Where's our treatment for malaria? Where's our capacity for our women to deliver babies? Once we met that, they allowed us to continue with the Ebola treatment center. And this happens time and time again, and I think we need to remember what the community's role is. And their voice needs to be put on the table.
Fantastic. Thank you very much, Maria. I want to come to the audience now. We've got 5 to 10 minutes to be able to take questions. So let me take this gentleman here. I'm going to take 3 questions and then come back to the panel. So please, if we can get a microphone down to this man. Yes, please. Yeah. If you could say who you are, where you're from, and then I'll ask you a question.
Thank you very much, great moderator and panelists. My name is Ibrahim Musa. I work for WaterAid. I'm in the Ghana program. It's lovely to see the first panel and this second panel, the great discussions. I wanted to remind us that, and I think the first panel spoke about it, last year in the Accord, one important thing that came through in this discussion we are having is to give water, sanitation, and hygiene the priority and support it deserves as probably the first step towards preparedness. Because like you rightly asked, Madam, the last question, community role. When epidemics or pandemics come, the first step is, do communities have water? Do they have adequate toilets? Do they have sanitation? And so it is important that as our leaders here go, and Her Excellency go through the next phase, I think we need to nail down in the articles the issue about water sanitation, and particularly so as we are heading to UN Water Conference.
Very good.
Yeah.
Thank you.
That's what I wanted to underscore. Thank you.
I saw a hand. Yes, please. Please put your hand up so the microphone can find you. Yes, up there, the woman in the beige jacket. No, the beige jacket. Thank you.
Thank you very much. My name is Qingyi. I am a student of global health at Yale University, and I want to ask a question on the financing side. And it's very interesting how our opening remarks brought up the different narratives around pandemic preparedness, such as biosecurity, humanitarianism, and of our sovereignty. And there has been increasing discourse about pandemic preparedness not moving on as in pursuing funding from ODA, but possibly from security, as outlining strategies of organizations like CEPI. So I'm interested in what the panelists think about the way forward of pandemic preparedness financing mechanisms, especially for the funds set up for this exact purpose.
Thank you very much. And there's a gentleman there with the microphone.
Yes, thank you very much. My name is Esteban Borrone. I work with the Medicines Patent Pool, MPP. So in the earlier panel, there was some conversation around what can we do to start operationalizing elements of the pandemic treaty. So I wanted to flag to the audience that yesterday at the MPP, together with Roche, we announced an agreement on an influenza antiviral. And the whole purpose of that agreement is to enable geographically diversified manufacturing of an antiviral that could be used both for seasonal influenza but also potentially for pandemic influenza. However, I think the key point here is that influenza is a bit the exception rather than the rule. There we do have some treatments, we do have vaccines. We heard last week from the Intrepid Alliance that most other pathogens of pandemic potential, or at least several classes, don't have products that are approved, don't even have in the pipeline, and in some cases not even in preclinical. And so what can we do, and here's my question to the panel, what can we do to try and promote and encourage and ensure there are investments in the development of therapeutics for all these pathogens of pandemic potential that we're not seeing today? And there are initiatives like the Therapeutics Development Coalition that are hopefully going to be launched soon. But how do we get people to actually invest in this, in the pipeline, as we know from the hantavirus and the others?
Very good, thank you. So water and sanitation, financing, looking ahead, and investment in research and development for therapeutics. Who's going to start? Helen, I'm going to come to you first. Which one of those three would you like to pick up?
Just perhaps on the financing, look,
Yeah.
I don't think we're going to get any money out of defence budgets. They're raiding everybody else's budgets.
Yeah.
You look at the UK, quite explicit. Yeah. We crash, ODA 40% to go into the defence budget, so forget it. Yeah. So I think come back to whether member states would be prepared to pick up and run with remodelling existing funding mechanisms and any new ones around the global public investment concept. We all pay in, we all have a say, and the allocation goes to those who need it most.
Yeah. Who would like to, else? Would you want to pick up on the...
On the R&D, yeah. And of course, we need more investments in R&D, but one of the things that I learned in the MPOX report, and it speaks also to what was said about water and sanitation, a lot of diseases can be prevented in different ways, and if we have, a more fragility-based vision of identifying where are the places that are at risk for certain, all these diseases that we're talking about are endemic. We knew in DRC, in Central African Republic, in Nigeria that there was MPOX. We knew, as Mariangela was saying, where there's hantavirus. So we can also think it doesn't always need to be biomedicalized, because also we know that we then enter always into all these commercial issues that we haven't found a solution to. I'm all in favor of doing, open research and development and develop medical countermeasures as common goods. But that's not what is happening today. But we can do a lot more also by providing the communities with the ways to protect themselves better and informing them and the whole trust issue. So I think we need to be careful to not over biomedicalize our response, because the basis is actually responsible healthcare systems that are resilient and that can work.
Very good. And then you comment on water.
No, can I just say, no, not on water directly, but I think we are facing other problems in the world, in the climate emergencies one, and access to clean water and safe water is one of the problems, right? So, Helen and some of us who've been on this field a long time, I think it's not only about pandemic preparedness, right? It's about public health emergency preparedness that we need to work on.
Okay. And Maria, did you want to have a comment?
Yes, sir. Well, I'll just shoot it out there. I don't know which question it will land on. But I mean, I think it's really exciting that there are all these initiatives. We have the Pandemic Fund. We have a lot of other Gavies looking at the fragile conflict settings. We also have the mechanisms of the IMCM net. You have all these initiatives. They need to be complementary to each other and not compete. And one thing that it needs to do is also co-design with the community. And I think by building that kind of input, that we know what needs to be targeted, and it has higher impact. But I just wanted to also say that to actually raise awareness, we need to localize, and this is the crux of what PAB's discussions is. It just needs to happen, and we need to not do it by voluntary because of goodwill, but because it is obligated, because it is about solidarity. And then lastly, on water, and I buy in a lot on planetary health, as you know, and I think because water insecurity, the climate emergency is going to affect us all. The tipping points are coming, and we think, oh, that's over there. And what's behind the hantavirus? We didn't speak about the other Lassa fever, which is a rodent-borne virus, which is blowing out of proportion in Nigeria as we're seeing Ebola. I think we need to start paying attention, and unless we really look at each other as one humanity, we will fail.
Thank you very much indeed. Please give a big round of applause for our panel. And now I'm going to hand over to Helen, who's going to give closing remarks.
Well, I mean, I think we've said it all, haven't we? That we need to finish the legal framework. Otherwise, years of effort are to no avail. Definitely the financing has to be addressed, and we need some innovative thinking of the kind that the GPI people have put on our agenda. But as I said, it all comes to nothing if at the most local level, backed up by national capacities, we can't be risk-informed, rapidly act, be able to test, then put in place whatever we know to try and contain an outbreak at source. And as I said, I'm not prepared to fault the international reaction once we've had confirmation, but back down upstream, I think there's more that we must support countries to do, and it will take some cash. So we do have a group of friends of the high-level meeting, including not only the independent panel, but also the elders, RANI, which was the Pandemic Action Network and now renamed, and 4PAWS, the very important One Health advocacy organisation as well. And as I said, we need to be quite concrete about what we want from this meeting. If we just go with a whole lot of woolly stuff, well, we'll get woolly stuff out the other end. We're suggesting maybe set some targets, target, member states getting the PABS annex done and agreement out of the WHA either by next May or extraordinary assembly before that, if that's what's needed, and then put the pressure on for ratifications. Otherwise, we'll stumble along to get the 60 for it to come into force. This could take a couple of years. Could we set a year? Be really ambitious, have some lead states around that. And then, maybe the high-level meeting could be very concrete about a roadmap, of benchmarks, along the way to better preparedness. I think it certainly must commit to One Health approaches, and then monitoring right from being risk informed through to how do we assess levels of preparedness, etc. That's a blank space at the moment. Final point would be, can we get leaders focused on it again, just to push it over the line? Leaders have really been disengaged for about the last 4.5 years, I would say. And without them giving their finance ministers a bit of a shove to be helpful to the health and other ministers who must respond, we're not going to get to where we need to be. So that's my conclusion. Thank you all for your interest. Thank you, moderators, and thank you.